Hi, everybody. I'm Sal Portugal, representing the Sports Economics Work Group. I'm presenting or I'll be introducing our speaker, Dr. Eliot Hu, who will be presenting on patient satisfaction in clinical practice. This talk will describe the components of value-based care and how patient satisfaction relates, compare and contrast components of patient satisfaction and patient experience, hopefully change the thinking of medicine to include business aspects, and discuss applications of relevant patient satisfaction, patient experience data to medical practice. So before Dr. Hu goes into his presentation, a little bit about him. Dr. Hu is a sports medicine physician and an interventional and diagnostic musculoskeletal and sports sonologist at the University of Massachusetts Memorial Health in Worcester, Massachusetts. He is an adjunct associate professor of family medicine at the Uniformed Services University of Health Sciences, associate professor of family medicine and community health at the University of Massachusetts Chan School of Medicine, faculty at the University of Massachusetts Primary Care Sports Medicine Fellowship, and current head team physician for the Northbridge High School in Massachusetts. He was previously the head team physician and director of athletic medicine at Yale University and was team physician for multiple professional and university teams, including DC United, Washington Nationals, and George Mason University. He also served as physician for the U.S. Navy, the U.S. Marine Corps, and consultant for the Marine Corps Special Forces and Navy SEALs. He is double board certified in family medicine and sports medicine. He is an expert in regenerative medicine, non-operative ultrasound procedures, diagnostic ultrasound imaging, peripheral nerve entrapment syndromes, chronic pain syndromes, concussion, and exercise-associated conditions. He currently runs a dilemma clinic practice where he takes on complicated and difficult cases. In addition to that, he completed his undergraduate studies at UCLA, his medical studies at Drexel University, and his family medicine residency at York Hospital. His primary care sports medicine fellowship was completed at VCU Fairfax Family Practice. He has been actively involved as a member of the American Academy of Family Physicians, AMSSM, and the American College of Sports Medicine. He sits on multiple committees at various national organizations and was elected as a board of director for the AMSSM. He is a consultant for multiple healthcare and pharmaceutical companies and has been invited to speak and teach at conferences nationally and internationally on a variety of sports medicine topics. He has also published multiple peer-reviewed papers, serves as editor for peer-reviewed sports medicine journals and textbooks, and has written multiple book chapters on various sports medicine topics. He also has a special interest and expertise in business aspects of medicine. So you can see why he's giving our presentation today. He has quite the background for that. Just a couple housekeeping things. Just please, you all received your email in your emails regarding renewing your AMSSM membership for 2026. In terms of questions this evening, please enter them into the chat and we will address them after our talk. So Dr. Hu, take it away.
Thanks, Dr. Portugal. Thank you for that introduction. I'm going to try to make this on time because I know the Yankees and the Red Sox are playing right now, and it's tied 3-3. So people are wanting to go and watch the end of that game. So without further ado, this is a topic that's kind of near and dear to my heart because patient satisfaction, I think when we first trained, or not necessarily when we first trained, but years ago when you and I did our training, it was still in that time period where the patients didn't really see themselves as consumers or customers. But as business crept into the practice of medicine, it started becoming more relevant as medical practices became business practices. And so I wanted to highlight this topic because there are people out there who are still very, very resistant to patient satisfaction in clinical practice. There are people who still don't understand that, and there are some intricacies that we need to go through. So without further ado, let's start on our journey. So first of all, I don't have any relevant disclosures, and we're going to go over some learning objectives here. So we are going to describe the components of value-based care and how patient satisfaction relates to that. We will compare and contrast components of patient satisfaction and patient experience. We're going to analyze how business considerations influence medical practice. Now, just a quick caveat, quick definition of medical practice. When we think about and when we hear about medical practice, a lot of us think about the clinical side of things. But nowadays, there's also the business aspect of things. And I think it's important to realize that, yes, there are clinical practice is very, very important, and clinical outcomes are very important, but also the business aspects affect the livelihood of your medical practice. Lastly, we're going to apply relevant patient satisfaction, patient experience data to medical practice. So first of all, the question that we should be asking is, what does patient satisfaction actually have anything to do with medicine? Like I mentioned, previously when we trained, it used to be the patients would come to the doctors and say, I believe everything that you're saying. I agree with everything that you're saying. You tell me to jump, I will jump through that hoop. Now it's a little bit different. Patients now are recognizing that medicine is a business, and what they want to do and what they're starting to realize is that they are the customers and they're the consumers. So the thinking and the mindset of the patients has actually changed to, well, I am the customer. Now it should be more of a shared decision making in terms of medical decisions, which is true, but also the business aspects has at least something to do with my satisfaction, whatever that may be. So looking at clinical outcomes, I think it's important to identify a prong study in Australia that is saying that, or that has shown that there is absolutely no association between clinical outcomes and patient satisfaction. But what this study doesn't portray and doesn't show are the other aspects that might influence clinical outcomes from patient satisfaction. So Cardis and Dietrich and Chrisman and Zimny, their studies and papers have shown that patient compliance and trust in their providers actually do improve clinical outcomes. So what we're going to do is we're going to talk about the associate or lack of association between true clinical outcomes and patient satisfaction itself. But then we're also going to talk about how patient satisfaction and patient experience indirectly influences clinical outcomes through compliance and trust in providers. So before we do all of that, we have to start from the very beginning. We have to accept that medicine has become a business. Well, what does that entail? What does that really mean? Well, there are increasing costs of healthcare. So everybody is thinking about, well, how can I cut costs? I mean, that's the easiest thing to do in any type of business is, well, if we're not making money, then we got to cut our costs. Instead of focusing on other aspects of medicine or other aspects of business in order to save what everybody else does, or what everybody tends to do in the very beginning is, well, how can I cut cost? So cost is a very, very big influencer of healthcare and also the business of medicine. With cost comes reimbursement and financial rewards, right? So, if you're not making any money, you can't keep your practice open. And big organizations, if they don't make any money, they're not going to expand services. They're not going to be able to hire people and provide all the cool equipment that you want to do and all the services that you're able to provide to the patients. So one side is increasing costs, but then we also have to maximize our reimbursement and financial rewards to keep everybody coming, to keep everybody working. Now, with that, I think, just focusing on the financial side of it, ultimately it comes down to healthcare now as a service industry. It is no longer I take care of you, you're going to do exactly what I tell you. Now patients are being seen as, by the organizations, by the businesses, as consumers and customers, and patients are starting to recognize that. I give an example of several years ago when I was still in the private sector working, and I was working in a late night shift. This was outside of sports medicine per se, which kind of had it's still related to it in a little bit. But a patient came in with abdominal pain, and she said, "Well, I want a CT scan." I was working in a freestanding ER at that time, so we had access to that. And so I told her, well, let me get all the history and let me examine you and I'll tell you what I think. And so I examined her, I got her history, and I said, well, I don't really think that this is appendicitis for where you want your CT scan. She said, well, how do you know? Well, I said, well, because I examined you, and it doesn't sound like with the history and the blood tests that you have appendicitis. I don't really think you need it. But she ultimately said, no, I want that CT scan. I want that CT scan. And she said, I am the customer. You're going to get me that CT scan. I said, okay, we'll get you the CT scan. So I got her the CT scan, came back normal. And I said, well, as I told you, CT scan was going to be normal. It is normal. And so she's like, well, what does that mean? And I said, well, I don't know. It tells me that it's not your appendix, like I told you. I think it's, your abdominal muscles or whatever it is. And she kind of huffed and puffed out of it. So, I think that example shows that not only do the organizations and the providers, are we starting to view medicine as a business, but the patients are actually catching on to this as well. So with the business of medicine, though, and with healthcare coming into its own as a service industry, there's going to be more marketing and advertising opportunities to get more patients and more customers into your practice, and patient satisfaction is going to be a big part of that. So the next step that we have to talk about is, well, medicine is a business now, but now a lot of people are, and a lot of organizations and leadership, they're focused on value-based care or quality of care. So this idea first came out of the Institute of Medicine, which changed its name now to the National Academy of Medicine. And they view value-based care or quality of care as something that's related to safety, time, efficiency, something that's equitable, effective, and patient-centered. It's deep, as they called it. Now, the Affordable Care Act took it to another level because now what they did was they said, well, that's the value-based equation that I'm showing you. But now 30% of your overall performance score is going to be, for value-based care, is going to be based off of the patient satisfaction and patient outcomes. And so this is reimbursement. They are tying reimbursement to quality, which means that it's coming out of outcomes and also that patient experience. So it does make a difference. And you do have to pay attention because healthcare organizations really do want federal dollars for this. And the Affordable Care Act actually codified that. So why does this matter? Well, I think it does play a role. You can't just say that quality, which means outcomes plus patient experience, is completely taboo. And I'll use the example, I recently picked up golf. And so, I bought a starter set and my driver just recently broke too. And so I'm like, well, I could go to Dick's Sporting Goods and just buy a driver, any old driver, or I can go to a specialty golf store and have them measure everything and check my swing analysis and then really match me to that driver. Hopefully I'll get another additional 20 yards, which doesn't really happen, by the way. But I use that as an example because if I, let's say, went to Dick's versus a specialty golf store, I'm probably going to be more satisfied with my experience at the specialty golf store than Dick's Sporting Goods because they treat me, like, I'm a VIP and, they customize everything to me. Whereas Dick's, I just go and basically pick it up. So that does play a role in terms of maybe the outcomes, but definitely plays a role in the patient experience as well. So if 30% of Dick's Sporting Goods profits are coming from my experience, they're not going to make a lot of money as compared to a specialty golf store. So this does matter. So this is the age-old story, right? So this is what a lot of people are focused on. Patient satisfaction versus patient experience. A lot of people use these two terms simultaneously. They use them interchangeably, but that is a big mistake. It is not the same. There are some overlapping areas, but there are specific differences. So patient satisfaction is specifically with the Affordable Care Act. It is measured by the HCA HPS HCAHPS score. It's mostly used for inpatient services, but it focuses on specific components of satisfaction. So whether that is provider communication, responsiveness of the provider, management of pain, medication communication, so education and instructions, transition of care, clinical outcomes, and meeting the patient's expectations. Those are the components of the HCAHPS. But a lot of people, they say, oh, Press Ganey is king, Press Ganey this, Press Ganey that. Press Ganey is not actually focusing on some of those components of true patient satisfaction. It is focusing mostly on patient experience. Now, what that is, well, you walk into the office and the patient room, how clean is it? Are the staff treating me with courtesy and respect? What are my wait times? And how long does my provider actually spend with me? Do they show concerns for my specific worries and my questions? How's my provider skill per the patient? Not necessarily true skill being measured by whatever metric it is. And then also, how do they keep me informed? So I think these are two very, very important distinctions to make, in that you can't really say patient satisfaction covers all of the patient experience. You can't really say patient experience covers all of satisfaction. Yes, there are overlapping areas, but I think people tend to focus on the experience side rather than the satisfaction side and those specific criteria when they talk about patient satisfaction and patient experience. So this is these are the players that are involved with patient satisfaction. We're going to go over each and one of these in greater detail. So first of all is location. So a lot of there are a lot of manuscripts and papers out there looking at patient satisfaction. What actually influences it? So the locations, the studies, and the literature have said, and they show that telehealth, and also if the patient has to travel long distances, that actually increases your patient satisfaction scores. So either you travel really, really far away or you don't travel at all, which is interesting. So if you really wanted to improve your patient satisfaction scores, you either offer telehealth or you move your clinic really, really far away from your patients, and then they'll be more satisfied. It kind of sort of makes sense to me. If I have to travel, let's say 200 miles to see the specialist, I'm probably going to be more satisfied if they did, let's say, an average job, rather than if I only had to travel 5 minutes and got an average average kind of subjective care according to my personal standards. Now, next, patient mood. Obviously, this one's pretty self-explanatory. So patients with depression and anxiety, definitely that decreases scores. And so patient mood has a lot to play with this. Access and time spent also increase scores. So self-reported health status. So if you have more severe of a condition, then the higher the satisfaction scores, probably because, yeah, you understand, or me as the patient, I understand how severe my health condition is. And if the provider spent a lot of time with it, and if I had to travel really far or not travel at all, I'm probably going to get some higher satisfaction, knowing that the provider spent some time to go over my severe conditions. Pain management and function, that's pretty obvious as well. If you improve the pain, improve the function, it'll definitely improve your patient satisfaction scores. Just today, I saw a patient that got referred to me, had 25 years of pain, really bad arthritis of the lower back and arthritis of the neck, had multiple surgeries, multiple procedures done as well, and still was in a lot of pain. And I examined him. I focused on his history, and I said, I don't really think that this is coming from your arthritis pain itself. And I think this is more peripheral compensation. And so I did a procedure today, the subtrapezius plexus that I hydrodissected, and did some trigger point injections and needling of his muscles of the neck, posterior shoulder area. And he walked out without pain, and he's like, oh, this was the greatest visit ever. So if you can control pain and you can improve function, that definitely increases your patient satisfaction scores. Now, patient and provider age also makes a difference. The older the patients are, the older the providers are, it actually increases score. This was something that was proven true actually by my parents. And so I remember when I was, back when I was still in California, my mom my mom and dad, they went to go see their primary care physicians who are, in their age, basically their 70s and their 80s. And so they would always, say, oh yeah, this doctor is so great, they know so much. And then all of a sudden, that practice hired actually one of my medical school graduates. And so she was 1 year behind me, did a geriatrics fellowship as well, so board certified in internal medicine. And the first time my mom saw her, she came back. I was like, oh, how was it? She's like, oh, the little girl saw me. She didn't know anything. I was like, little girl, she's my classmate. She graduated at almost the same time that I did. She went through extra fellowship. What do you mean she's a lawyer? She didn't know anything. And so, my mom wasn't very satisfied because she saw somebody younger. And then my father, as well, I'm a sports medicine physician, double board certified in family medicine, sports medicine, have all this experience as well. And then he says, well, sure, I appreciate you, seeing me for or talking to me about my pain, but I'm going to go check with my doctor and check if you're correct. And I'm like, okay, I guess you're not very satisfied with my care. You can go see your doctor. But I think patient and provider age does play a difference here. So provider specialty, the surgical specialties and OBGYN has been shown to have higher patient satisfaction scores than primary care or medicine. So I'm not exactly sure why that is. Maybe because they're a higher level of care clinically, maybe. But at least patients perceive OBGYN and surgical specialties to be more satisfying than their primary care or medicine. Patient education can go either way. Studies and literature says that it goes either way. Either you can give too much education or give too little education. That'll sway it either way. And provider communication, good communication, does increase the patient satisfaction scores. So historically, how we're trained is, the patients are going to listen to me. I am the physician, and patients can be accustomed to that, where, okay, you are the doctor, you tell me what you want me to do. But I think the times have changed. There are definitely different players that play into influencing patient satisfaction as well. So what is the end game? What is the result of all this? What do we want to get out of all of this? So we talked about a lot of the business side of medicine. And so a lot of this is focused on what does it get back for me or the organization in terms of the business aspects. So patient loyalty is a big one. So patients, if they're more satisfied, obviously they're more likely to return for future care. So, if I, said, I'm going to open up this practice, I want patients to come back, because now if they leave, I have to spend extra time to recruit another patient and get them to stay as well. So patients as customers are very, very important. Retention. So they are more likely to retain their health plan and retain their physicians and their services if they have higher patient satisfaction. Obviously, customer service. So that actually helps out with your staff because if they're more satisfied, then they tend to voice fewer complaints. And on the other hand, what they can also do is that they might bring stuff to thank you. And so I remember, in my previous practices, I treated a patient, and then sometimes they would send these fruit baskets. Sometimes they would send a cake. I said, well, go ahead and leave it for the staff. And so the staff are happier as well. Patient satisfaction does increase healthcare costs. That is proven too in the literature. And so, yes, we are more prone to ordering unnecessary tests, focusing on pain management rather than treating the underlying cause, because sometimes patients as customers just want that. So profitability, there's mixed data, but really what's important to everybody is show me the money. So Cuba Gooding Jr. had it right, and Jerry Maguire, Tom Cruise had it right. Show me the money. That's really what organizations and practices have to do with patient satisfaction. But it doesn't mean that money is the complete end-all be-all for patient satisfaction. I think there have been studies in the literature that show that if patients are highly satisfied, then the provider can be very satisfied as well, and they can decrease burnout in clinical providers. But we talk about clinical outcomes again. Is it truly no association according to Prong and the Australian study? Maybe we have to start considering the compliance side and also the trust in the providers. So benefits and disadvantages of patient satisfaction, patient experience. So the benefits, obviously, we went over this: patient retention, patient relations. You can get better payer reimbursement, maybe get some free marketing, because if they're satisfied, then they will definitely spread the word. Years ago, when I was in private practice, I took care of one runner out of a whole running club, and they were very, very satisfied with my care. And so then within the next month or so, I saw everybody in that running club. So they can be very, very powerful marketing tools as well. So profitability, literature has shown that it may or may not be that big of a factor with patient satisfaction, but definitely patient compliance and trust, it can lead to better clinical outcomes. The disadvantages, though, of focusing on patient satisfaction solely or a majority of the time is that we're definitely increasing healthcare costs. So patients may or may not be that well versed or educated in their medical conditions and tests and workups and treatments, but they want what everybody wants, right? With pain, they want their pain to be controlled. Well, they just want to figure out what the problem is. And so we may be more pressured to ordering unnecessary tests and costly treatments. Maybe not for the better, but it does influence patient satisfaction. It might change the way that everybody practices medicine, right? So it may be that instead of practicing value-based care or quality care, we may be practicing preventative, well, I wouldn't call it preventative care, but I would call it kind of litigation or cautious care. So we're trying to avoid being sued. We're trying to avoid being targeted, and we're trying to avoid dissatisfying that patient. So we might change the way that we practice. Patient expectations might change too, just because of their satisfaction. If they're very, very satisfied, then they might give you a little leeway, or they might have very high expectations. So it goes both ways. But it definitely increases the provider burden because we are no longer just clinical clinicians and clinical providers. We do have to worry about the business aspect. We do have to worry about the patient side of things, not just clinically, but also socially and emotionally. And it does contribute to provider burnout. So just to recap, the Affordable Care Act codified that patient experience in value-based care. And so it's a part of the quality. So it's 30% of the reimbursement. Patient satisfaction is not always the same as patient experience. There could be overlapping areas, but they are distinct, two distinct things. So most benefits of patient satisfaction, they are related to business, but can possibly have some indirect effects on clinical outcomes, which may be related to patient compliance and provider trust. So I like this slide in a lot of my slides when we talk about business of medicine, because there are those physicians and providers out there who are still very resistant to accepting or even understanding the business of medicine. But the train is leaving with or without you. And so it's really your choice. But patient satisfaction, value-based care, like I said, the Affordable Care Act, it's all codified, it's law. And so it's here to stay, and the train is going to leave with or without you. So it's your choice whether to get on or not. So thank you for your attention. I'm happy to answer any questions that anybody has.
So if anybody has any questions, feel free to enter into the chat. Eliot, thank you for that excellent presentation. Patient satisfaction, I think is an excellent, it's a great topic that really needs to be revisited every few years. You and I, and I'm sure many others on this call, have seen the evolution of the dynamic between the physician and the patient. Early on in medical school, it was very much patients, at least in my experience, where whatever you tell me, doc, that's why I came to you. You're the expert. Let me know what you think I should be doing. And very much the focus was on, okay, really get my medical clinical acumen down, then I can spread the word, right? But over time, it almost felt like what you were kind of describing is this consumerism within medicine, and almost like that patient was always right. And then how do we come to terms with that? And I think medical schools now do an excellent job of emphasizing that shared decision making, right? Informing the patient, try to kind of guide them, translate their options. So just a few of my observations. Looks like we do have a question in the chat. First comment is great. Thanks so much. Question is, how do you deal with a patient that becomes disruptive when they don't get what they want right away? Usually the physician gets in trouble if the patient causes a scene.
Yeah, that is an excellent question. Certainly, I have had my share of that as well. So, I think it depends on, number one, how supportive your organization is of you and your leadership is of you. If your organization and leadership believes in you, then you have a lot of leeway here. And so, if you have strong leadership who say, well, I understand, sure, we'll talk to the patient and we'll try to work things out, but we don't want you to sacrifice your views and sacrifice your values and morals to satisfy the patient. The customer is not always right, and we all understand that. It's not truly a business aspect like that, but certainly there needs to be shared decision making. So I think it's a good question. So what do I do when a patient becomes disruptive and they don't get what they want? Number one, I see, are they actually rude or not to my staff? Are they actually acting like a child, or are they actually, do they have a problem and are willing to professionally resolve this? So if they are really, if they're acting like a child and they're rude and all that, then I say, no, I'm not going to deal with you. But if they are professional about it and they have a genuine inquiry and they're saying, well, this is what I think, I tend to work with them. I tend to say, well, let me get back to you on that, because let me do a little research and see what else I can do for you in terms of finding maybe some scientific evidence. Maybe it's there, maybe it's not there. I certainly don't have all the questions. But I found that talking to the patient in a professional manner, in dealing with them professionally and admitting that I don't know everything, I will do the research and see what we can come up with and come up with a shared decision with you. That usually is pretty beneficial for the patient, number one. Number two, it's more satisfying for them. Number three, it doesn't put your staff in the middle of everything. And then number four, if I don't know anything, if I don't know a lot of this, I did the research, I did the education, and I learned something from it. So I think there's two different ways to approach this. One is, well, how childish are they really acting when they're quote unquote disruptive? And so, with my patient, when I wanted a CT scan, I basically just threw in my hands. I said, okay, sure, go ahead. But I didn't offer any other treatments after that. I said, follow up with your primary care. You don't have an appendicitis like you thought you did. Had they been more professional with me, I probably would have said, okay, let's work things out a little bit. I probably would have offered something else too, in terms of treatment. It just depends on what that experience is for me, what that experience is for my staff, and what that experience is for the patient. Every player has to have some sort of say in it.
And I think that's an excellent recommendation and approach to that. And I think most important is actually what you said first in terms of understanding your institution. Not every institution is as supportive of the physician, unfortunately. And I do think that it is requisite that you unfortunately, or not unfortunately, fortunately, actually should focus on partnering not only with the patient, but partnering with your administration to ensure that they have your support, or you have their support in dealing with any kind of difficult situation. So another question, great talk. What would be your top 3 things you would implement to improve patient satisfaction in a clinical practice?
Yeah, that's a great question. I think that's how do we apply these principles to our practice, to our clinical practice. So number one, I would look at the just like I said, I would look at the leadership structure and the support historically. Has the leadership historically been supportive of providers, or have they historically been supportive of just the patient side of things, right? So if there's an organization out there and all they do is say, well, I'm just going to listen to the consumer or the customer, that might not be a great way to improve patient satisfaction in clinical practice. And that might be something to examine to improve in order to improve patient satisfaction in a clinical practice. Because if patients get all their way, sometimes they might feel better the day of in terms of emotions, in terms of mental health, but clinical outcomes or pain management even, they probably won't have that satisfaction score from that category. So I think we need to examine and maybe re-examine the leadership structure and the support that's currently there, and make changes there if needed. Number two, what I would say is top number 2 on my list would be to look at department or clinic policies in terms of dealing with a difficult patient or interactions with patients. You know, are we being the most professional that we can as staff, as providers? And then what happens if, like you know, the previous question, you get a really disruptive patient and it's just unreasonable? What is the clinic policy? What is the department policy of that? You know, so if the department policy is the patient is always right, the customer is always right, you're not going to get a lot of patient satisfaction out of it. If the policy is we're going to be firm on this, we are acting as professional as we can, and the patient needs to be professional as well, and you know, treat everybody like adults, you know, and start acting like an adult. I think that will definitely help to improve patient satisfaction and collaboration and communication. Number 3, I think the top number 3 of what I would do to improve patient satisfaction in a clinical practice would actually be to keep an open mind. This is on the provider side. And so keep an open mind. And what I mean by that is be accepting that we may not know everything. And so we might be the super specialist at the very end of the road, but we certainly don't know everything. There's certainly things out there that haven't been researched on, haven't had the evidence, but maybe they're onto something. And so I would never tell the patient, and I would never tell anybody that, no, they're wrong. What I'm saying is absolutely correct. I would say, well, I don't believe that, but let me research it. It makes sense. And it makes sense to me where you're coming from, but I want to research it and I want to see. I want to confirm, and let's see if we can communicate and be better and get better collaboratively, rather than saying, well, I'm just going to listen to X, Y, and Z, or patient A, B, and C and just do what they say. I think that does improve patient satisfaction. So the example that I'll give is that when I was at Yale, I was in so my patient population was a whole bunch of Ivy Leaguers. And so they're really, really smart. They're probably smarter than I am. And so every single time that they had an issue that they didn't understand, they would send me an email and say, can you explain that to me? I'd be like, yeah, sure, I'll explain it to you. And then they would follow up with an email with like 5 other questions. I loved it because I'm like, well, not only are you learning, but I'm learning too. And so I think that really, and that drove home patient satisfaction too, because historically at that institution at that time, the students weren't very satisfied with, at least the student athletes weren't very satisfied with their care. But certainly, you know, during my time, I didn't have anybody complain about the care that I provided and the care that they were receiving, because I was very open about it. And I was very open about, well, I don't know. Let me research it and I will get back to you, and let's do the research together. So I think that does play a role, the communication side and being open-minded and accepting that you don't know everything, even though you might be the super subspecialist.
So just comment on that. I think that was a great answer. It summarizes a lot of challenges I've had early in my career thinking, well, how do I respond to this when they're asking for numerous tests? You order the test because it's been 45 minutes of arguing to find out that we're very unhappy that you end up ordering the test. But those 3 principles would have saved me that frustration. So the next question. Is there anything you do special in your clinical practice that you feel improves your patient's satisfaction?
Yeah, this is pretty important as well. So just a little history of my clinical practices. So after fellowship, I went into private practice for several years, and then I joined Kaiser for several years. So I did a capitated system for several years, and then I went to Yale and did academic practice, but just with the athletes. So it's a very closed off, closed system type of academic practice. And then I went to the military and worked there for 8 years. And then joined University of Massachusetts, now in an academic type of practice, but still kind of large organization, private practice, maybe that type of setting as well. So initially in private practice, what did I do special? You know, I remember very distinctly, this was 13 years ago. One of my partners actually at that time referred me a patient, And, I went in there and no laptop in front of me. I basically, sat right in front of the patient, eye to eye, communication, and just, basically let the patient, tell me the history, examine the patient, offer my treatment options and all that. Nothing out of the ordinary. It's pretty bread and butter stuff, nothing, special out of that. But after that visit, I didn't hear about it, but my partner said, yeah, my patient came and told me, I totally have doctor crush. He made me feel like I was the only person in the room. I'm like, that's basically what I try to do with every single patient. And so that's what I am trained to do. And I think if you treat everybody exactly the same, it doesn't matter. Yes, you're going to get those VIP patients who either demand a lot or you want to devote a lot of your energy to. But if you devote that same type of energy and effort to every single patient, I think patients will recognize that and they appreciate that and they will be more satisfied in a private practice setting. Now, in that capitated system, it depends. And so that capitated system of Kaiser, you're a little bit restricted in terms of resources. But the thing is, what I did in that system was I said to the patient, I am limited in what I can do, but I will sure fight the darndest and hardest to get you the things that you need. And then, I would always keep communication via email or I called the patient after, let's say I did a peer-to-peer or whatever it is. I would always document it, shoot them an email, and call them. And so that communication also improved my patient satisfaction score. So that's something that's special that I did in a capitated system. In that tightly knit, closed academic system at Yale, I just mentioned it. I think having that collaboration, knowing your patient population, and keeping that open mind and the urge to keep learning and the acceptance that I don't know everything really helped me in that setting. In the military population, I've treated generals, I've treated Navy SEALs, Special Forces, I've treated the little recruits that come in as well, but I treat all of them the same. And my patients all say that, I don't care if, you made me feel like you didn't care if I was a general or, just a recruit coming in. You treated me exactly the same, offered me everything exactly the same as if you would offer this 5-star general as well. And I say that's exactly what I try to do, and that's where I think a lot of the special things that you do in clinical practice may not be special clinically, but I think socially, emotionally, professionally, that can all be improved too. Certainly, it helps if you have a special set of skills to, let's say, control pain with my dilemma clinic skills. I think that does play a role. But certainly, you can always, pick up more education and more clinical skills along the way in order to improve that. But I think your personality, you have to know your personality. You have to know your patients really well, and there has to be a form of communication and an art of kind of taking care of the patient, as my mentor would like to say.
I think that's fantastic advice. It also just kind of sharing along the same lines, mistakes I made in terms of walking in the door initially thinking, okay, I know the exact treatment plan that this patient needs. I see it's clearly a lumbar radiculopathy. We know what the algorithm is for treatment of that. But if you're going in with a mindset of not necessarily partnering with the patient and translating what they're going through and fully understanding, that patient will never be on board with your plan. So that's great advice. Any
Yeah,
other
just to go
questions?
off of
Yep.
something that you mentioned a couple questions before remind me of something as well. I didn't touch upon it in this talk, but there was a previous economics webinar on social media, and so social media now has been pretty rampant. A lot of people use it, and some people use that as an outlet for their dissatisfaction. And so ways to potentially improve your patient satisfaction and actually get those patients back. I remember when I was in private practice, I hounded Google, I hounded Yelp, and I basically picked out all the ones that were negative. I called them and I said, hey, I'm sorry for your experience, but I'd like to change that. And so they all came back and they said, well, you made a really, really big difference. So that's something also that you can improve your practice's patient satisfaction scores too.
And it looks like Andy has put the YouTube link in the chat. So if there's no further questions, Oh, actually, real quick before I make that announcement. So they're actually right before this, the email went out yesterday, reminding us of this talk today. I actually got a message from another physician regarding a TikTok link that was featuring a physician stating to a patient that lower patient satisfaction scores equate to better clinical outcomes. So, fake news. But it's funny that you mentioned social media, so I just wanted to
Yeah,
throw that out there.
I don't
You'll
know how
probably
much of
get
that
that
is
link at
true.
some point.
Yeah, I don't
So
know how much that is true. I can say that there's no association according to that Australian study, but I can't say that lower patient satisfaction scores equate to better clinical outcomes. I can't see that. But hey,
agreed.
let me do some research on it. Let's see.
So as a reminder, next webinar is on December 17th. We will be focusing on how to utilize industry funding for research with Dr. Nicholas Bird from the University of Illinois. Obviously, feel free to reach out to us if you have any questions. This will be available on YouTube. And please do remember to renew your membership dues. Thank you, Dr. Hu.
Yeah, thanks, Sal.